Good afternoon, everybody. We are going to start by launching a quick poll for you to take. We know that this was a pretty big topic that we wanted to discuss, and we know that we get a ton of questions about training. And definitions about training, where does training apply, what can we spend money on, what we can't spend money on. And so we really wanted to take this opportunity to discuss some of those definitions, kind of extrapolate a little bit about what training is, but also hear from a few states as well about some of their examples of how they've maximized or used SHIP grants for certain training. So we will hear from a few states here in just a few minutes, but to get started, I really wanted to just kind of dive in and maybe ask everyone, what's your definition of training? You can see our definition of training. This is what's on our website. But does anybody else have, besides what's on the screen, does anybody else have a definition of training that they use in their state or prefer, or what do you guys think this training definition here on the screen is pretty accurate? I would love to hear your feedback or your comment in the chat box, or not. It's fine. You don't have to do it if you don't want to. But yeah, we set out last year or last spring when updating the allowable investment search tool. We really wanted to kind of define training a little bit more, because it was just like training is allowable, but then we got a bunch of questions that were like, but what about this training, what about this training? And so what is training, right? And so training, as we define it, is training is defined as learning a specific skill or process from a professional, business, or subject matter expert to improve outcomes and outputs related to a SHIP approved category, and is an allowable expense. And we went back and forth on this. This is not necessarily the government definition of training, and we want to make sure that that's very clear, but this is kind of how we define it. And note that it's like from a professional, business, or subject matter expert. It's a SHIP approved category, but is also a allowable expense. Sometimes we can say, hey, this will improve patient safety, but it really doesn't fit a SHIP category. And so Caroline, next slide, please. And so we wanted to list out and talk and go through some of the allowable training types. And again, we know that several of you had questions, and this may invoke some more questions from you. So please think about any questions you have, put them in the chat box, come off mute, scream at me, throw something at me over here in Oklahoma City, whatever you want. When you see this list, we're more than happy to have an open discussion about it. And so thank you for those of you that have chimed in about the definition. And so some allowable training types, patient safety. And we're going to nuance that here in a second. Efficiency or quality improvement for VBP, ACO, or PB, PPS, which are the three spending categories. Alternate payment models, quality payment programs, computerized provider order entry. Pharmacy services, there is a catalyst with this. Pharmacy services does not include the actual distribution of a medicine or to pay for salaries, or nor does it include day-to-day operations such as printers or labels. Population health, social determinants of health screening, systems performance, community paramedicine, HIT, there's a missing parentheses there, I'm sorry. ICD, notice I did not put 10 or 11, hot topic. S10, price transparency, and telehealth and mobile health, hardware, software, and services. And so that last one's usually the one that kind of gets interesting, right? Well, what does it mean for training on hardware, software, and services? And so taking this list in line, is there anything there that stands out to you that you need or would like further clarification on? And I'm going to go back and I'm going to touch on a few of them specifically like I did. If there's something specific that you would like clarity on, or have a question about, or want to chime in and yell at me, that's fine. Go ahead. Or give me a high five. But so patient safety does not mean, these are a good question. This is the big one. Patient safety does not mean the actual prevention or treatment of a safety to to prevent an injury. So patient safety training is about how to see and notice a fall risk, not putting bumpers on a bed to prevent somebody from falling out of a bed. It's training to see if somebody might be, to notify if somebody might be a faint risk, not how to treat them if they do faint, right? So you can't order. A couple of weeks ago, I had to get stitches about a month ago, and I passed out in the doctor's office and was not expecting it. Hadn't eaten all day. I was like, guys, I feel a little faint. The next thing I know, I had a lollipop and I was coming to. And so the lollipop would not be an allowable expense, but noticing and training on how somebody, those are the type of patient safety things that we would include. So,
Matt,
yes,
Miss Sindra from Montana asked, how about leadership training?
sure. Leadership training is a great non-allowable expense. And that would be on that's going to be on the next page. So leadership training in general cannot be allowable. So that's very interesting because obviously if you're going to take a staff member and they're going to be trained in some of these areas, they're going to be leaders, and it doesn't mean that Darlene, I see your question about health equity and training, and also Joyce about your level 4. Level 4 trauma center. So leadership can be a little bit iffy. I mean, you can take some like lean classes, those are allowable, things like that. And those all cater towards leadership. What we can't do is say, this is how to, we're going to do a training on just how to be a good leader. Right. That's not allowable. Now, the center has tons of leadership videos that you can utilize for that. And I would tell you to use those if they need training. But to call someone in specifically and say, hey, we're going to just lead and show you how to be a good leader, that's not going to be allowable because it really doesn't fit a finite spending category that SHIP has. And so that's really important to note. And we understand again that if you're going to get ICD-11 training or you're being training in a certain specific area that does meet, ACO or PPS or whatever, that may be a leadership thing, but leadership in general, no. And so level 4 trauma center training, Joyce, I need some more details about that. It sounds like that would be direct patient care. It also sounds like it would end up with a certification or credentialing. So those two things I would say off the top of my head that would not be allowable. And health equity, Darlene, that's a great question. Health equity definitely falls in. Caroline, if you'll go back a slide. Health equity would fall under population health and social determinants of health screening. Health equity falls under both of those categories. And so the catch of here is like you can do screenings and you can train and have the different services to identify. One of the things is we talked about identifying a food desert or food needs as a population health or health equity issue. And something that can be done is you can train your staff on how to identify whether or not there is a food disadvantage, or maybe someone doesn't have enough nutrition, or someone's not they are in the hospital because they're not getting enough food. You can train for that. You can train for those type of health screenings and those type of trainings. What we will not pay for is putting a food bank in your hospital, right? Or putting, giving groceries out or gift cards out or solving that problem. So the idea is to identify so you can come up with a solution. And this is where partnering with other organizations or other grant programs may be beneficial. Other programs may be able to pay for that. And so you can do the training with SHIP to identify these areas and then do a training in a different area under a different spending category, a different income, or a different expenditure account to do the actual execution. So, and that would include, they're like, oh, can we print business cards? Can we pay for business cards? Now we don't allow for printing and printing services. So it can be a little frustrating, but the idea is, again, almost goes back to, we want to train hospital staff to know how to identify these things better so that they can point them in the right direction. But that end result there, like where they go, whether it's a partner, transportation, all that, those things we cannot provide. I hope those make sense. I know we had ICD-10 and 11 as a big thing. A lot of people ICD-11 is allowable starting in next year, 2023, Kim. And so that's a big thing. You guys have already submitted your stuff for your applications for next year, 2023, the next funding cycle for 5 years. ICD-11 is something that we ask you to make a priority, and under the intention that sometime over the next 5 years, the United States government will ask all hospitals to start implementing. And so we wanted to give you a funding opportunity. I say we, it's a royal we, not me. They wanted to give you a funding opportunity to be able to say, hey, we are ready. We have been bringing it up. And for hospitals that haven't been thinking of it, it's now time to start thinking about it. And so a great example is maybe you already pay for ICD-10 software, and that ICD-10 software is going to upgrade to ICD-11 at a future state automatically. Well, that would count for ICD-11 preparedness and readiness because it's a software that will automatically update. Big questions that we sometimes get are telehealth and mobile health, and these are questions that we still ask internally. And so continue to ask those questions if you have them. But basically we will pay for the hardware, software, and the training for that hardware and software to implement telehealth or mobile health in your facility, so long as we do not pay for the actual treatment, diagnosis, maintenance of a patient. And so we will pay for the computer and the laptop and the things so that you can have telehealth in an emergency room. So your people in your rural hospital can now telehealth with someone in a metro area that is a specialist. We will not pay for that visit. We will not pay for that doctor's fees. We will not do all that, but we can pay for the computer and the software that connects everybody, if that makes sense. So just keeping that in mind. So next slide, we already looked at it a little bit. Some that are not allowable. The biggest thing is direct patient care, media or marketing, leadership, certifications or credentials, medical direct patient care, or medical devices. So Bluetooth stethoscopes was a big topic conversation year before last. You cannot Bluetooth stethoscopes. The only reason to buy a stethoscope is to hear a heartbeat or listen to lungs or to listen internally to a patient. And that is considered direct patient care. Now, if you just have a software, if the hospital wants to buy a software that will import or connect that Bluetooth with a computer system on the back end, we would pay for that, but not the stethoscope itself. And so again, I want to remind everyone that direct patient care occurs when a facility, its providers or staff provide services directly or indirectly to diagnose, stabilize, treat, repair, maintain, or improve the health of a patient regardless of patient status or location, including med surg, emergency room, waiting room, ambulatory, and is an unallowable expense. Telehealth subscription fees, Wanda, yes, they are, as long as, yes, well, the short answer is yes. So if you're paying for a telehealth software like every month, and that keeps you connected, then yes, that would be allowable. We will not pay for the doctor's visits, and it can't be for like one specific doctor, like, oh, in order for that. But if it's more of like a program that will allow you to connect with specialists, things of that nature, that would be allowed, yes. That's where if you look up on the search tool, you'll get into like subscriptions are not allowable. And what we really want you to avoid is like magazine subscriptions or open-ended subscription to training. We also want to avoid subscriptions to medical journals, things that like anyone and everyone can access at any point for any reason that's outside of the scope or within the scope of SHIP. And so just open-ended subscriptions are not going to be allowable. So next slide there, Caroline, thank you. And so here's some questions that I asked and that I wanted to put on this screen so that you guys can see. When I get a question in the inbox, these are kind of the questions that I ask. And so does the training fall under a SHIP spending category? Usually before you guys ever send us an email or even send a FORP email, you've already got that down. So we appreciate that. And we would appreciate, even if you don't do that, to kind of, if you want to send us, hey, is a microphone allowed under ACOF or whatever? That helps us know what you're trying to think of. And does it's a real simple one. Does the training require touching a patient? That's not necessarily a done deal, but we do. That's the first question because that usually leans it towards no. Does the training increase the quality and efficiency of the hospital surroundings and systems? Right. So if that's a yes, then we kind of go back and forth and we say, okay, well, it could do this. And this next one, will the training incur a certification expense, or is a certification the end result of training? Tricky subject, very interesting subject, right? Your training may include a certification or some sort of certification expense. SHIP will not pay for that. All right. So let's say you're going to do a training and it's built in that it automatically ends with a test, and the test is a credential or some sort of certification. I have passed the Diet Dr. Pepper test, right? And you can hang this piece of paper up and you're a Diet Dr. Pepper technician now. That's great. We'll pay for the training so long as it's one of the spending categories and it meets the quality of SHIP and, patient safety, whatever it is that you decide. We'll pay for the training, but you have to itemize out the certification and the testing part every time. There's really no exception. There are very few exceptions to that. And so almost all trainings will automatically will need to be, the certification and the testing part will need to be excluded from that. And usually you can get a company to say, okay, we can break that down, right? So the training is, $2,000 and the testing was 500 of that. And the hospital will just need to find funding for that other $500. Again, I would encourage you to look at other grants in other areas to see that if there's some sort of partnership or some sort of teaming up that these grants can do. But we do get a lot of questions about certification and training. Just make sure that what you submit does not include the certification. The hospitals submit do not include the certification or testing costs. And that's real simple. And then, of course, the last question I ask is, will this hospital training be used for direct patient care? Different than touching a patient, right? Direct patient care, actually treating the patient or diagnosing or whatever. And so we really want to make sure these are the questions I ask myself, and these are the questions that the team asks when we get any one of your questions. And so may be helpful if you're finding that you're asking a lot of questions to ask yourself the same thing and to kind of work through it real quick. One thing that we've gotten to is like, what about workshops or that type of training? Yes, those have to be PO approved. And they're going to look for, we got one earlier. I got your email, you know who you are. And so what we have to do is we have to see the agenda for the event. We have to make sure that at least the majority of it would address SHIP and SHIP spending categories. So it may not say SHIP on the agenda for this conference, but if on there the categories or the conferences or meetings or breakouts are SHIP related, then there's a chance that the project officer will approve it. And so make sure that if you're doing a conference or things of that nature, that you send that information on. What will not be covered are meals, extra add-ons to the conference, transportation, hotels, things of that nature, mileage. We cannot cover that. And so just keeping that in mind. So next slide. I want to discuss some things that we often have. And I want you guys to actively participate in the chat if you can. So let's start with the top. We might skip around on some of these. So I've already talked about this. Bluetooth device training. What do you guys think? Yes or no? Is it allowable or unallowable? What do you think? Type in the text box or the chat box, or come off mute. Feel free to say with confidence your answer. Bluetooth device training. What do you guys think? Allowable or not allowable? That is correct. It would be allowable because it's the training of the device and the reading and the software, but not the actual treatment of the device. So let's skip down to AED training. What do you guys think about AED training? AED training, that's their little shock pads. Correct. That is not allowable. The actual training on the okay. So Dorothy, that's a good thing. Allowable so long as there's no patient contact. So that's a good comment, although an AED would always have patient contact. One thing that maybe it wouldn't be but it wouldn't be considered AED, it'd be patient safety training, is like training your hospital staff to know where the AED devices are. That seems like it would be allowable under patient safety, right? Improves response times, et cetera, but does not train you on actually how to use the AED device. What about crash cart training? This is a tricky one. Any comments or questions about that? Right. Okay. Yeah. Good on crash cart training. It is allowable so long as the crash cart is you're not training on how to treat the actual patient, right? So if you're looking at just training on where the items are in the crash cart, where it's kept, how to access it, how to even stock it, things of that nature, we would allow that. What we can't do is say, we're going to train you on how to use the items in the crash cart. Like that's a nursing thing, that's a credentialing thing, that's a medical treatment thing. No. But if you're training on them on how to get it in the room, where to put stuff, things like that, as far as really looking at more response times, then that would be allowable. Again, yeah, some people have do mannequins. And so you really want to be careful though with that. So the mannequins are fine, the training aspect, but the AED itself, the training is intended to only be used on a patient. Like you wouldn't ever see AED training used anywhere else. Like how would you use that training? So that's kind of an important aspect there. So you're not actually using a patient. And we had this conversation a lot with like IV insertion, right? Like, whether or not that would be allowable. And at the end of the day, if you're training on how to insert the IV, then that wouldn't be allowable. Now, if you're training on how to identify whether or not someone needs an advanced PICC line or a different type of IV, then we were getting into some more considerable aspects there. So those two down here is active shooter training and stop the bleed training. Allowable, unallowable.
Does everyone know what stop the bleed training is when Matt says that?
Probably not. So stop the bleed is a training to identify or to, if somebody is bleeding, to be able to tie off on the blood to stop the bleed until medical personnel can get there to show up to stop in an active shooting situation or a fire situation of some sort. Yeah. Yes. So recently we have added under allowable, the active shooter training is allowable. It is not a direct patient care. So what we're talking about when we say active shooter training is not how do you respond to patients or to people in the hospital that have been shot, but how do you prevent, right? So, here's what you can do. You can shut the doors, you can turn off the lights, you can run, hide, fight, that type of stuff. Yes, because that's not actually patient training. For a long time, that wasn't allowable because weren't able to define the difference, right? So this is more about preparing your hospital or the staff to what to do in the situation of an active shooter. Stop the bleed is literally medical treatment. And so we would not do stop the bleed training. So it seems interesting. Stop the bleed seems like it would be more allowable because of a patient safety, but that's actually medical treatment. So interesting concept, but active shooter training is something that is unfortunately needed and is allowable. And so good conversations. And this is the type of conversations we have internally as well as these come in and we say, hey, what about this? What about this? Feel free to shoot us more emails with your questions, your concerns, or hey, we mentioned something in the webinar, or I saw something, I want more information on that. And so infectious disease training is allowable if it is about disease registry or if it is about identifying diseases, not on the treatment of infectious diseases or the treatment or diagnosis of infectious diseases. So official diagnosis. So I think that's important to note here too. And so at this time, I would like to invite a few people that are with us. I think I haven't checked the roster And so I think, let's see here. Who do we have up first? I think it was supposed to be New Mexico, but we may skip to South Carolina and Britain. So, Britain, we are going to call on you to kind of share a little bit about what's going on in South Carolina, what you guys have done in the past.
Yeah, absolutely. So, hi everyone. I'm Britton Herbert. I'm the program manager of Health System Innovation here at the South Carolina Office of Rural Health. In my role, I manage the SOAR, Flex, and SHIP grants, and I've been with the office for a little over 5 years now. A few things I want to mention help lay the groundwork for my piece. First is that we are a small state in terms of relative number of facilities in comparison to many of you. We have just 4 critical access hospitals, which will be down to 3 in a couple months. And including those, we have 12 small rural hospitals participating in our SHIP program. But despite the small number, they still cover the gamut of critical access, PPS, independent, system-owned, and a spectrum of affiliation relationships, which fall between there. Next item to mention about our program is that we have historically pooled all funds into the SC SHIP network, through which all activities were completed. I know this right off the bat is a departure from the way I'm sure most of you handle the program. And we have recently made an adjustment for the fiscal year 23 application, which we just submitted. Going forward, most facilities will split between the SG SHIP network and to gain access to all of the trainings that we're offering, and also receive a portion of the funds to apply to activities specifically identified as eligible and top priorities for their organization. So this change really was made to help ensure that everyone retained access to the statewide trainings while still recognizing that there are differences in the needs across the spectrum of participating organizations. So with that said, I'll speak a bit to the training aspects of our program. The pooled funds from the SC SHIP network allow us a significant purchasing power for training and allows access to education that our big financially backed hospitals and our least fiscally inclined facilities alike can have access to. There's a couple of trainings which we have offered annually focused on the payment bundling or prospective payment systems investment activity B, the ICD-10 training. Through this activity, we provide 2 training events. The billing and coding boot camp each spring, once CMS has issued those final rules, and the evaluation and management documentation training towards the end of the year. So these really work to ensure that hospital staff understand these core elements and have access to the changes and updates that persistently come to them. These things are just always being updated, and missing those updates or misunderstanding those updates can really have an impact on facilities' financials and ultimately patient care. So we used to offer the E&M trainings and the 2-day billing and coding boot camp in person. It's been virtual since COVID came into our lives, which comes with the usual impact of a bit higher attendance as the burden of travel is removed, but also the lack of the same level of engagement interaction between attendees and presenters and amongst attendees themselves. For now, we're going to keep it virtual, but that's kind of subject to change as most things are. We put out pre and post knowledge surveys for the event to assist in measuring the benefit of the content and gauge whether the presenters should be the ones that we continue to work with in future years. Another element to note that, as was mentioned earlier, the SHIP funds don't cover CEUs and certifications. Most vendors, ours included for this particular, offer these items, but as a cost to the attendees, should they desire them. It can very easily sometimes have those items rolled into a quote or payment, and it might not even be specifically identified sometimes. So it's always important to kind of check that when you're going with the vendor and make sure you're all on the same page. As I'm sure is fairly fresh on the minds of everyone who submitted the application in the past few weeks, the focus on ICD-11 readiness, moving beyond our good friend ICD-10 and looking to the future. This is an element that we're wrapping into our annual trainings as well, including an additional training focused on ICD-11 readiness. The scope of this training will evolve as the details surrounding it are released, but offering these trainings on this allow us to ensure that each facility is providing the focus due on this topic, as it's being a specific focus for our program for SHIP-wide for this coming year. So those are the trainings we offer annually, but We've historically also included additional areas of interest. These are identified through two methods. The first being an annual SHIP network meeting, during which we gather input from our network leadership. And secondly, through an annual survey. We provide the survey to our SHIP participant leadership and other members of the organization, which detail out various areas of need that they may be experiencing and options for how they might be addressed best. We use the survey to identify what areas we should include in the next year's training agenda as we're filling out and building that application each year. For the current year, there was a high demand on operational efficiency trainings under the payment bundling or PPS investment activity C. We're currently identifying trainers to come for this opportunity and offer some lean training to the facilities. We've previously offered trainings which were identified as needs through these different routes, including pricing transparency, population health, and S10. But the survey also presents an opportunity for identifying other needs within these facilities that perhaps the SHIP program may not be able to address, but maybe Flex or the SOAR grant or secret other option you may have can cover. So this is a great way to think about that overlap amongst not just the grants to maximize training, but also from one grant to another, really across the spectrum of the services you have to offer. Many organizations which offer these trainings all have large caps of how many people can attend for a flat fee, typically just because it's being utilized by one organization. But the benefit of offering these trainings through the network is the ability to take advantage of that flat capped fee and fill it with individuals from multiple organizations. It's extremely beneficial for our small facilities, which would ordinarily not have nearly the number of people or potentially the financial resources to purchase a large class like that. So they can send their few relevant individuals and still reap the benefit across their organization. So that's really how we maximize our staff training in SC, working to provide the right trainings relevant to the needs of the hospitals and in a way that facilities of all size can get the benefit. I'm always happy to discuss the details and ideas with anyone about SHIP or any of the other grants for that matter. So just reach out, and thanks, Matt, for having me.
Yeah, I have a follow-up question too for you. And sorry, we left that slide up. So you were a tiny little screen that whole time, and I apologize. We'll get it right this next time.
Oh no, you didn't have my face giant in front of your screen.
I know, it was such a sad time for us. If you have a question for Britain or South Carolina, feel free to put it in the chat box. We'll also make sure that in the recording of this that we put contact information. Britain, you mentioned a boot camp. Explain to me what that, what does that look like?
So it's kind of flashy style to it essentially, but it's a 2-day training event. Like we had it in person, it was our boot camp. Everyone just came, same room, and kind of had that camaraderie of going through the steps and learning together. So it was a lot of the basic information at first, I think, is kind of where we came up with the boot camp, and it's stuck.
Yeah, no, that's awesome. Now, was there anything, I know you mentioned several different things that had been done training on. Was there anything in South Carolina recently that you can remember that were like really important things to train on? Like you were like, hey, we're lacking in this area and we really need to pick up?
I mean, recently we certainly had the focus on pricing transparency, both because that was a focus highlighted from the SHIP program itself to make sure as we're being addressed, but also from the survey and kind of gaining the input of the SHIP hospital staff. That was something that, especially since at the beginning of that, there was a lot of changes in what some of the specific requirements were and what we were looking for, and that's still kind of something that's evolving. That's something we've had a couple of training opportunities on.
Well, that's awesome. Well, thank you, Britton, for your time. We really appreciate you and the work you do in South Carolina. It's always a pleasure. Again, if you have any questions, I think a few people gave their appreciation to you, and we appreciate that. And let us know what questions you have for South Carolina, and we'll pass them on. And at this time, we're going to go to New Mexico. I do believe Martina is going to introduce Stephen. Martina, are you here?
Yes, hi. I'm Martina Garcia. I'm the New Mexico Flagship Coordinator, and I want to introduce our contractor, Stephen Studdard, with the New Mexico Rural Health Network, and he will talk a little bit about the lean training for materials management directors.
Great. Stephen, welcome.
Thank you. It's good to be here with you. All right. Can I share my screen?
You sure can.
I've got a few slides just to share to talk about explain what we're looking at here. So, all right. Well, thank you. It's great to be with you today. A brief background about me. So I work as the executive director for the New Mexico Rural Hospital Network. And with ACHE, I'm currently serving as the ACHE regent for New Mexico and Southwest Texas. And so with those responsibilities, I get a lot of opportunities to network with people and just be well aware of what's happening all over our region. And these are just some of the other things I've been able to do in my work history, as well as some other opportunities with boards and so forth. I got my MHA from North Carolina in Chapel Hill, and then my bachelor's degree from Brigham Young University in Provo. And I'm married, have 3 kids. Our oldest daughter is a labor and delivery nurse. She just started this year in that role and loves it. We have a son in college and then a young daughter in 3rd grade as well. And those are some of the things. But in terms of, if you've never been to Albuquerque and New Mexico, this is what we're known for, is our International Bloom Fiesta. We just had that last month. A lot of people love to see it. This is one of our family's favorite events that we have here in the area. So our network, we were started in 2011. We had 6 original members, and then we received a network development grant through HRSA, like a number of networks across the country. At that point, our CEOs that had started the network decided they needed to hire a full-time director, and that's when I was hired in 2015. We currently have 11 hospital members in our group. So we've grown tremendously over that time. Here's a list of our different facilities. A good number of them are critical access hospitals, but others are PPS, various sizes. But the commonality is they're all rural, independent, and nonprofit. And here's on the map geographically where our members are located. And we are very spread out. I mean, literally, I'm based in the Albuquerque area. For me to get to my furthest hospital in Lovington is almost a 6-hour drive. It's about over 300 miles to get to that hospital just from here, which is somewhat in the middle of the state. So we are very spread out. There's huge distances involved. And because of that, we do a lot of our work through virtually, as well as some in-person opportunities for our members. So we're focused on supporting and sustaining quality healthcare in our communities through collaboration. And that's the key word, is our collaboration efforts. We do have a vision as well to be the leader in quality for rural healthcare through education, advocacy, sharing best practices, and also group leveraging to obtain better prices on things. Over time, one of the things that we focused on has just been setting up a number of business partnerships. And these have been helpful for our members to, since they don't belong to large systems, to access things at better prices and be able to have a better level of service as well and recognition than if they were on their own. The other thing has been, we've established these peer network committees. Currently, we have 18 active groups that meet regularly. Each of our committees meet quarterly. 3 of those meetings are virtual, and then 1 meeting for each group is in person at one of our hospitals. And so we stagger those throughout the year, make sure that we have that opportunity for face-to-face networking, visit another facility, have a tour, learn about it, and so forth. But today I'm going to talk specifically about our facilities management directors group and some training that we through SHIP focused on with them. This is actually just one example. This is our lab group. They met this summer at one of our hospitals for our in-person meeting. We took a quick picture in the conference room there. So our lean management training, and I'll have some pictures over on the side. This is some of them are they're all from COVID. We were very focused during that effort to help get additional supplies that were donated out to our rural facilities. But I have a few photos of some of our materials management directors during that time when we were getting emergency PPE out to these facilities. So we organized 2 different lean management training sessions for our materials management directors, that specific group. We have one in May of 2021, and then a second one in May of this year. And the first one we focused on, we had the manager of process excellence from the Presbyterian Health System. Now, Presbyterian in New Mexico is the largest health system in our state. They have, the largest tertiary facilities. They have a number of other facilities, even some rural hospitals all over the state. But this was a unique situation because Presbyterian is not a member of our organization, but they were still willing to work with us and provide some education and share some expertise with us. So during that presentation, we had 6 people that were representing 5 of our rural hospitals, and that one was a virtual education. And it was good discussion, good insights, very helpful information. In fact, this is one sample slide of some of the different categories. And what our goal was with this initial presentation and education was to focus on just a high-level overview of what lean is and what it consists of. And that's what this person provided for our group. These different categories, some of the examples that can be used. How do you make your area more efficient and your process more efficient? And what does lean mean and how do you do that? And it was very helpful because a lot of our members have not even heard of lean or have very little experience or education around this topic. Then our second presentation, and again, these are some other materials directors during the pandemic and some of the supplies that we took out to them. But the second education and training was provided by the quality director at one of our facilities. He's actually a member hospital in our group, and he's a black belt certified in Lean Six Sigma. And so this was really good too. The exciting thing about the second program was primarily the fact that, hey, it's from one of our peer hospitals. It's in a rural environment. They understand the limitations, the staff challenges, the unique aspects of being in rural. And so they had more relatable examples for our members that were very helpful. So the second time we had 9 attendees, and that represented 8 of our 11 hospitals on that training. Here's a few different slides and examples that were shared. And so these are some material specific examples in this second presentation. So this shows some examples of how things were stored, that they had lots of boxes. They pointed out that now they take all the supplies out of the box. They make sure everything's in a bin or on a shelf and that it's much more organized, easier to visually keep track of where you're at, and a more efficient process. Here's another example. They were looking at, hey, by the way, this row right here with the purple lids, you could literally squeeze another shelf in there. And so they've done things like that. They figured out, okay, how do we use this space more efficiently rather than having big gaps when we really only need this much space for a certain level of product. They also talked about sometimes you're overstocked on different items, and how do you reduce your supply and reduce your stock to run appropriately. And so they pointed out sometimes departments run out of an item and then they just order 100 of whatever it is and they are overstocked. And it takes, if you have more than a year's supply worth of whatever supply you have, then you know that you've got too much and you need to kind of back off and figure it out and manage it a little bit better. They talked about things like eliminate what you can. And especially things that might be expiring, or they notice things like sometimes, here's an example, light bulbs for equipment that you don't even use anymore. They found things like that. So it really takes some effort to go through, organize, and not just organize, but also organize what you really use and what you really need in your facility, and be ready to change that and update that as necessary. These are some visual examples as well of switching over to bin systems and how much more accessible and organized that process can be. So in summary, you know, both training sessions were really valuable for our members. There were several materials directors that were interested in following up and creating this two bin system process where you have, you know, two bins of the same product. When you run out of that first bin, you pull the second bin forward, and then you stick the empty bin somewhere to get filled up again. It's an easy way to visually go through and have your inventory in control. Another aspect that we did talk about is, you know, one of the concepts in lean management is just-in-time inventory. And that didn't work so well during the pandemic. You know, people, when the supply chain is messed up, the whole idea with just-in-time inventory is that you literally receive your supplies, you know, within a short time of when you actually use it. So that way you're not storing it for a long period of time and you don't have all those costs. So financially, it makes a lot of sense, but it only works if the supply chain is not broken. And so during the pandemic, it didn't work. We talked about some of the issues with that. If you've got ongoing shortages, ongoing back orders, you can't follow that type of a model very effectively at all. You have to have some extra stock on hand to take care of those things. So this is a picture of the Rio Grande, not too far from my home here in Albuquerque. And these are the Sandia Mountains in the background, but just a visual example of the area that we live in. So that's just kind of a brief summary of that particular project that we've worked on. You know, as I showed you, there's a number of different committees. We have a lot of different education programs that we focus on. But this was one that we have done in the last couple of years that we felt like has really been valuable for our members.
Well, thank you very much, Stephen. We know that, number one, New Mexico is a very beautiful state. We appreciate you sharing that picture. And of course, all these slides will be available on the website afterwards that we will send out. If you have questions for Stephen, please put them in the chat. We'll make sure that he gets them or Martina gets them, and we will make sure we follow up with that. And so for the sake of time, we're going to run over to Nicole in Maine, who is going to share a little bit about what they are doing up there in the Atlantic Northeast.
Good afternoon, everyone. I'm Nicole Breton. I'm the director for the State Office of Rural Health and Primary Care. For our SHIP grant, historically, we work in a network. Our office has pulled all of our funds together. We put a request for proposal out for a subject matter expert to work with all of our 20 rural hospitals. Maine has historically had 100% participation with our SHIP program. We make it easy. We don't buy subscriptions, hardware, certificates, or certifications. We keep it just basic subject matter expertise on mostly revenue cycle management, financial and operational improvements. And for today, Matt asked me to speak of one particular project and regarding some time and letting New Hampshire being able to speak on their project. We work closely with our vendor and we meet with our hospitals. We have been meeting virtually. We've started meeting in person. We work together on individual needs assessment and then also a bigger needs assessments for all the hospitals. And one of our biggest issues that we've had is our medical denials. And so with our hospitals, they were at across the border about 15% for their denials rate. BNN, Baker Newman Noise, who we work with as our vendor, worked specifically with them sending all of their denials to BNN. They share their denial rates unblinded with each other. And when they meet, they discuss them. Baker Newman Noise does the analysis, comes back with like the top 3 denials claims that they have. And then they work together, troubleshoot, provide that subject matter expertise of what's happening and what the solutions are for the billing and coding office to work on to fix that. Over the past several years, our billing, Medicare billing and denials has been reduced from 15% to just under 4% collectively for all of our hospitals. So huge benchmark. This is an area where our hospitals really, we have kind of encouraged them to move on to some other areas, but they really want to keep working on this, especially with the continually turnover in staffing that our smaller hospitals have experienced. Some other projects that we are working on is the same as South Carolina. The price transparency has been a big one. And then also some more hospital specific is emergency department flow throughs to make sure that everything is following a systemic order and everyone knows the processes, and including the billing and coding office, so they can really be talking to patients and be feeling comfortable talking with patients, so they understand what may be covered, what not might be covered, what to expect if they do have insurance. And then if they have no insurance or they're underinsured, they are able to feel comfortable and confident of talking with them about different sliding fee scale programs and that person-to-person contact and having that relationship with the patient directly, not hiding behind a phone or, you know, through communication through the mail. And that has helped tremendously build our confidence up with our billing and coding staff within our hospitals.
Well, thank you, Nicole. We really appreciate you sharing with us what's going on in Maine. One common thread, and Darlene had to step out real quick, so she offered her apologies. So we do want to make sure everyone has an opportunity to ask questions. But one thing that you noticed through all of these, there's a lot of emphasis on efficiency and organization and flow, and how the hospitals are operating in that respect. And so that's a really important aspect when it comes to training. And so I apologize for not starting my video earlier. I was just chatting away. And so that's an important aspect of this, you know, training. And, you know, is it making the hospital better? Is it making these efficiencies run smoother? Or you know, there's an opportunity to save money, whether it's lean training or price transparency or just the work, you know, the work through in the emergency department, making sure that the coding and billing people are also involved in that. And so sometimes we take a very singular approach to training and it has to be only these people. But, you know, if you widen that out, it can be a leadership training type of training. It can be a physician type of training, and they're all on the same page. It increases efficiency and streamlines the approach, which increases patient satisfaction, increases spending. It really just not increases spending, decreases spending and efficiency. And so that's just really great aspects to consider on the training. And so these were, we really went into this webinar today trying to just give you some examples of training. These, thank you very much to the states that shared, and to go through the allowable training types and to kind of quiz you. What do you think? How do you think? This may open up a lot of questions for you, and that's fine. That's what we're here for. You can always email us at, you know, ship-ta@ruralcenter.org. as you guys all know, you can, and we'll be happy to discuss with you. We've had one-on-one calls with states to just talk through training and talk through different allowable expenses. And so we really want to make that opportunity for you. We are also very, very, very proud of all of you for getting in your SHIP applications. We know that that was not an easy opportunity or an easy experience for a lot of you. Some of you had not been here previously for the last one, and this was your first time, and you did great. Thanks for hanging in there and asking hard questions and helping us be better. And we learned a lot. I learned a lot, way more about ICD-11 than I ever thought was possible. But that's because of y'all. And so I really appreciate you, and I appreciate your hard work. And as always, and you hear me say this a ton of time, the work that you're doing, these little nuances, trying to figure out allowable expenses, somebody's getting better healthcare because of the work that you're doing. And so please continue to be an advocate for rural health, for your rural communities. This Thursday is National Rural Health Day. So we'd encourage you to post something on social media or to tell your friends about that, and just bring awareness to the needs of our rural communities. And we've launched the poll. If you haven't taken it, please take a second to give us an answer so we know how we're doing and where we can increase our training to y'all next time. And so we really appreciate you guys. And if there's any questions, we'll stick around here for a few minutes and be willing to answer them. And so other than that, y'all have a great day. We appreciate you. Thanks, Megan. Shirley, are you getting snow this week? I just called Shirley out. I hope she's still there. My bad.